All right, so we are going to start talking about Chapter 12, Neuromuscular Electrical Stim for muscle strengthening and enhanced motor control. We're going to talk about general considerations to begin with. Just like we talked about in the introductory chapter, we're going to talk about electrode placement and contraindications and precautions. Since we've already gone over those, I'm not going to go over them in detail, but unless they're specific to this application, there are some that are specific to this application. So let's just jump in. The learning objectives are to define neuromuscular electrical stimulation, what it is, identifying the similarities and differences between NMES with functional electrical stim, FES, being able to describe the effects of electrical currents on innervated and denervated muscle. So are we stimming the muscle through the nerve, which is closer to the physiological reaction, and we're going to review that anatomy and physiology a little bit, or are we stimming the muscle directly because it doesn't have a nerve? You should be able to state 6 clinical applications or clinical indications for electrical stim for strengthening, based upon the desired outcomes of your electrotherapeutic treatment. Defining the differences between voluntary or physiological excitation of muscles and electrically induced excitation of muscles, and the implications for treatment with NMES. You should be able to describe the electrode type and placement you would use for a treatment. And what are motor points? And explain the general considerations for implementing a clinical treatment program that includes NMES and the special considerations for pediatric clients. Even though we're not going to go over it in detail, you should be able to explain the contraindications and precautions for the applications of electrotherapeutic procedures. So we talked about that in the last chapter. All the same things still apply. So the ICF Model, the International Classification of Functioning, Disability, and Health, neuromuscular electrical stim may be used when impairments in structure or function are identified that require modification of neuromuscular activation and control. So if you have muscle weakness, denervation of muscles, muscle atrophy, those are all impairments in structure or function, and we might need to change neuromuscular activation to get better control. NMES might be used when activities impeded by the identified impairments impact the participation in life roles. So you're not just going to stim people's muscles for the fun of it. You're going to do it because you want to improve their function. So we need to have functional goals that address the activities component of this. And we'll talk about goals and how we're going to assess things and outcome measures. Modification of the impairment by NMES may permit the client to more fully participate in their life roles. That's our goal. We want to get patients more functional, more able to do things that they need to do for their life. Across all the interventions we do in PT. So the indications for neuromuscular electrical stim, there are 5 of them on this page and then 1 on the next page, just so you know that's the 6 in the learning objectives. To increase muscle strength is one of them. And there are asterisks on those. Well, that means we'll talk. Let's talk about these. To enhance performance in a healthy muscle, we rarely use that in PT, but a lot of times in the athletic training world they will use that, and we'll talk about the pros and cons of that. To improve muscle endurance, to facilitate range of motion, to modify spasticity, and to enhance motor control. So either to facilitate a purposeful movement or as a substitute for a passive orthosis. And we'll talk specifically about those as well. So just to review, when we voluntarily are trying to elicit a muscle contraction using our brain and our nervous system, we activate smaller motor units of muscle And those smaller motor units served by smaller diameter axons are activated first. So that's the first thing that happens. There is a predictable order of recruitment from small type 1 muscle fibers to larger type 2 axons and motor units. Okay? So we get the little ones first and then the big ones. And our nervous system decides which ones get activated first, unless we're using some kind of external intervention. Small axons are more fatigue resistant. Thus, fatigue occurs during high-intensity voluntary contractions. Asynchronous activation of multiple motor units. And again, our nervous system gets to decide how it's going to activate motor units. So a lot of times after a neurological event like a stroke or a brain injury, the nervous system can't do that, and so you get synergy patterns. And we'll talk way more about that in neuro. We want to get a smooth functional motor contraction, and that happens when you have a voluntary muscle contraction. Usually with a voluntary muscle contraction, you don't get onset of fatigue until you get to relatively high intensities or durations of activity. So their voluntary muscle contractions are more fatigue resistant than electrically stimulated ones. So with electrically evoked muscle contraction via transcutaneous stimulation of the peripheral nerve, which is largely what we're doing, you get stimulation of mixed nerves, so you get sensory and motor stimulation, meaning pain may accompany stimulation. When you make a voluntary muscle contraction, you don't usually get pain with that. Sometimes you do, but you don't get pain because you're stimulating sensory nerves at the same time. Your nervous system picks which nerves to stimulate. When you have an electrically evoked muscle contraction, there is an unpredictable order of recruitment. So you get type 2 recruitment preferentially. So those are the large, more fatigable axons and motor units. So axons that are closest to the stimulating electrodes are more readily recruited in a non-selective, spatially arranged fashion, versus the physiological stimulation, which recruits it in a smoother manner. A lot of axons are activated synchronously instead of just as needed. And there's more potential to activate the type 2 easily fatigued motor units at lower contraction intensities, which results in earlier onset of fatigue. So electrically evoked muscle contractions are not as fatigue resistant as voluntarily physiologically evoked contractions. And electrically evoked muscle contractions lack smooth grading and functionality. So they're different from your physiological muscle contractions. So in the action potential is propagated along motor nerves. That action potential crosses the neuromuscular junction at the motor point. That's where the nerve enters the muscle, and the muscle contracts. So in a physiologically initiated contraction, usually we get the slow twitch, fatigue-resistant type 1 muscle fibers activated first. With electrically stimulated, we usually get the fast, not as fatigue-resistant type 2 stimulated first. Muscle twitching. The physiologically initiated muscle contraction has a low contraction force. Electrically stimulated has a high contraction force. The physiologically stimulated has a slow speed of contraction. Electrically stimulated has a fast speed of contraction. Physiologically initiated muscle contractions are fatigue resistant, they're atrophy resistant, and we get asynchronous recruitment. With electrically stimulated contractions, they fatigue more quickly, they atrophy more quickly, and we get that synchronous recruitment, so it's not as organized and functional. So strength duration curve, it comes back. So, really the strength duration curve is your sort of your guide for this whole set of chapters. You should have it with you at all times, in your brain, if not physically on a piece of paper or in your book. So the strength duration curve is going to tell us what we're doing with this external electrical stimulation. So what we're trying to do with neuromuscular electrical stim is we're trying to stimulate action potentials in motor nerves. That's the purple line on the graph. The amount of electricity required to produce an action potential depends on the type of nerve. So short pulses for sensory nerves, longer for motor nerves. So we're going to need a longer pulse duration to stimulate those motor nerves. Innervated versus denervated muscle. With an innervated muscle, the action potential is propagated along motor nerves, and fast twitch type 2 muscle fibers are activated first by those motor nerves. In denervated muscle, electrical stimulation can produce contractions only when the pulse duration is at least 10 microseconds. Sorry, milliseconds. Microseconds is for nerves. Milliseconds, which is 3 orders of magnitude longer, for stimulating the muscle directly. So it takes a lot more electricity, a lot more pulse duration to stimulate the muscle cells directly. So are we usually doing that? No. Do we usually have a denervated muscle? No. If we can use the nerve to stimulate the muscle, that's what we're going to do. We're going to stim the nerve, and that's going to stimulate the muscle. If we don't have that, we'll talk about why we want to do the denervated muscle later. So, here it is. Here's why we want to do it. So, by electrically stimulating the muscle directly, it may retard or reverse loss of strength, atrophy, and fibrosis in the muscle. So this picture is from the book, and it shows muscle fibers. The black areas are muscle fibers that have atrophied and died off, basically, and developed fibrosis in place of the functional muscle fiber, so that muscle's not going to be as strong. For denervated muscle, we need a long pulse duration and direct electrical muscle stim. We're usually using continuous direct current. We're not necessarily going to get improvements in functional outcomes, but we are trying to retard the loss of strength and atrophy. And this is in the case where we expect hopefully the innervation is going to come back. You have a peripheral denervation injury, and we want the nerves to come back, so we don't want to lose muscle while we're waiting for that. When you're talking about something like a spinal cord injury where the muscle is not going to be reinnervated, there are different considerations, and we'll talk about that in the next section. So electrical stim strengthens muscles the same way that lifting weights strengthens muscles via two principles: the overload principle and the specificity. So the overload principle is you have higher load and higher force contraction and greater strengthening. So the progressive overloading, the old story probably from ancient Greece, where the guy starts picking up the baby calf and picks it up every day to take it over the fence, and eventually he's lifting a full-grown bull. I mean, obviously it's a myth, but that's the idea, is that you're progressively overloading the muscle. So with electrical stim, we're using increased pulse duration, amplitude, electrode size, and external resistance. That's how we're creating our higher load, a higher force contraction, and greater strengthening. So we're trying to overload the muscle to strengthen it. Specificity, where the muscle contractions specifically strengthen the fibers that contract. So electrical stim has more of an effect on type 2 muscle fibers than type 1. And disuse atrophy is primarily of type 2 fibers. So that's why electrical stim can be used in disuse atrophy, because we're strengthening those type 2 muscle fibers. The implications of all of that are that neuromuscular electrical stim is not a substitute for voluntary motor activation. Evoked muscle contractions fatigue more quickly because of early recruitment of type 2 motor units and synchronous excitation rather than that asynchronous. So we want to select stimulation parameters that minimize fatigue. So we'll talk about these individually. We want to take into consideration the frequency of the stimulus in the pulses per second, the duty cycle ratio, so on-off times, which the off times are rest periods, and the progressive strength of contraction. So the brain picture here, it's just a lovely picture of the primary motor cortex, which is coordinating all this in physiological motor activation. So for NMES, we want the electrodes that we choose, we want to minimize impedance, which is the resistance. We want to have uniform conductivity, ease of application, hypoallergenic, cost-effective, variable size and surface area. So we want them to be large enough to activate adequate numbers of motor units to avoid high current density, skin irritation, and especially when we're stimulating large muscle groups. So the most commonly stimulated muscle group is the quadriceps. There are various reasons, which we'll talk about. But if you're stimulating a large muscle group like the quadriceps, you need large electrodes. We don't want to have so much current density in one area with a small electrode. So bigger electrodes for bigger muscles. So for electrode placement, we want to find a motor point. So the motor point is where the nerve enters the muscle. There's not a thing like the carpenters use, like a stud finder to find where to put the nails in. There's no such thing for motor points. You have to do it by trial and error. So if you've got electrodes on where you think the motor points might be, and you're not getting good muscle contraction, you may have to move your electrode to find that motor point. So there are some maps for motor points for specific muscles, and this is a picture of one of them. But do people's bodies always follow these diagrams? No, they don't. So take-home message, you might have to move your electrodes if you're not getting a good contraction. So monopolar is one electrode over a motor point, and the second electrode is on a remote area. That's just to complete the circuit. And that's when you want specific small muscle recruitment. Bipolar, they're closer together. We're trying to get a specific muscle to recruit. Closer interelectrode distance, meaning they're closer together, you get a more superficial current and more activation of sensory fibers. Larger interelectrode distance will recruit larger or deeper lying motor units with large electrode pads. So remember that for your electrode placement. How close you put them together affects how deep or superficial you are stimming. So the size of the electrodes depend on the muscles to be stimmed. You want to cover the maximum surface areas of the muscles. So big muscles, big electrodes. You want to place the electrodes wide to maximally recruit deeper lying motor units, especially for those large muscle groups. So the quadriceps are on this page, the hamstrings are on this page. We are trying to recruit deeper lying motor units for those larger muscle groups. So you want to really orient and educate your patient to what you're going to do. You want to tell them what to expect with sensory and motor responses. They're going to get a lot of sensory as well as motor, and it has to be tolerable to them, but strong enough to recruit muscle fibers. You want to tell them what to report to you. So what they feel and whether they're feeling the muscle twitching and that sort of thing. And whether, so a lot of times people will say, oh, well, this one electrode is really stinging. You might need to move it to another location. You want to pre-inspect the skin and make sure you have intact skin and intact sensation. Really, really important for neuromuscular electrical stim. You want to monitor the patient response during treatment and check their skin if they report discomfort. If they say, I feel a burning or stinging underneath this one electrode, you want to stop the stim and check under that electrode. Afterwards, you want to inspect the skin, and if there's any redness, which there might be, it should disappear within 24 hours. So you should tell your patient to take note in the next 24 hours if there's redness and let you know what happened to them. and what their response to the treatment was. So sometimes I'll even have people take a picture of it if they have redness or other skin effects that don't disappear within 24 hours. So with kids, careful instruction is super, super important. And you have to do a trial of them to permit the child to get used to the sensory stimulus. Little kids have small limbs. Small electrodes for small limbs. So that might concentrate the current and result in skin irritation or burn. Kids also have more sensitive skin. And so there's also a phenomenon of volume conduction in small limbs where you're stimming muscles on the other side of the limb because it's not as deep. So you really want to take, if you work with kids, you really need to take these things into consideration. With kids, of course, this goes for all PT treatments besides, including electrical stim. You want to incorporate treatment into play functions. So it can't just be they're sitting there and you're doing this to them. It has to be like you're stimming their quads, they have to kick a ball when they feel the electrical stim go on or something like that. Children don't just tolerate having things done to them the way adults do. So first, do no harm. That's rule number 1. So we always want to consider contraindications and precautions. Contraindication is a condition that cannot be altered and precludes the use of electrical stim. If you have a contraindication, don't do it. Don't do electrical stim. A precaution is a condition that may be modified or for which, if you take additional care, it may permit the use of electrical stim safely. That's key, safely. So these are all our contraindications. These are the same ones we discussed in Chapter 11. Nothing's changed with that, but it's all listed here. And precautions as well. Patients with cancer, you don't want to do electrical stim over areas of active or previous neoplasm. You want to consult with the physician and the patient, and you want to document that you have both of their informed consent. So written documentation and patient consent and physician consent is advised before you do electrical stim in patients with cancer. You want to avoid placing electrodes over compromised or fragile skin, except in cases of electrical stim for wound care specifically. So elderly people have fragile skin. You might not be using electrodes on an elderly person's fragile skin. Tissues that are vulnerable to hemorrhage or hematoma should also not have electrodes placed over them. And people in cervical or craniofacial regions on people with a history of CVA or seizures. You just don't want to mess with that. So you don't want to operate electrical stim devices within 5 yards of diathermy units or other sources of EM radiation. We'll talk about EM towards the end of the quarter. Obviously, you don't want to do electrical stim while operating hazardous machinery, driving, or doing an activity that could inadvertently dislodge an electrode or adjust the amplitude of the device. You want to monitor pain medication intake to establish the efficacy of electrical stim versus pharmacological agents. This is a whole list of references talking about that you can look through.